Since these studies have been conducted, I've changed my practice of how I inject and tend to use ultrasound when they don't have a good response, not initially, but also I tend to use higher doses first, based on the studies showing that it was safe to inject 2,500 units as the first injection into the parotid gland and the submandibular, 250 units of myoblock in the submandibular, and 1,000 into each parotid.
Do you do submandibulars and parotids on everyone, or do you?
So I've changed now with these studies showing that it was safe, because I was concerned about the safety of injecting submandibular, and usually would reserve that based on their response and increase the parotids, and then the third time maybe add the submandibular. But now seeing that even with anatomical localization, it was safe in these studies, not just safe in the pivotal blinded randomized part of the trial, but also on subsequent injections that patients had over a year period, I began to now inject both the parotid and submandibular every time.
So what's your starting dose that you're using?
1,000 units and 250.
Okay.
But if somebody had a lot of dry mouth, if they had some swallowing problems that weren't so clinically evident, but we knew they were there, then I might start with 750 and 250 or 750 and avoid the submandibular the first time. So I still adjust it to the patient, but in general, unless there's a reason not to, I'll give 1,000 and 250 on each side as the first injection with anatomical localization, although sometimes I use ultrasound for the first time as well.
And how high a dose will you go with myoblock?
Yeah, so the two doses that we tested in the trial were 2,500 units and 3,500 units. So I'll go from 2,500, and if they don't have a full response and there's no side effects, I'll move routinely to 3,500. I'll move to 3,500 units, giving 1,500 units into each parotid and 250 still into the submandibular for a total of 3,500 units.
So you're keeping your submandibular dose constant, and you're just raising the.
Yeah, and it's not based on the science of what we need to block the release of acetylcholine. It's based on the safety that was found using that paradigm in the trial.
Do you find your dose escalating or drifting up over time? Some patients who do well at a lower dose suddenly aren't doing as well, and you have to give a little bit more. I've certainly had that experience. I don't know if you've shared that.
So I tend to repeat the 3,500 units with ultrasound before I go above it, to make sure that I'm at the right location and right depth. And then if they're still having a problem and they don't have side effects, then I'll go up a little bit more. I tend not to increase the submandibular just because I don't know the safety of increasing it. But I tend to increase the parotids more, maybe up to 1,750 or even 2,000 units in each parotid.
I've gone very high. We've had this conversation. I think the highest dose I gave was 14,000. And a lot of my patients settle around 5,000 units of myoblock.
What do you tell patients when you inject them? Do you tell them this is going to get better today, next week? How long will it last? When should you be re-injected? What types of things should people know if they're going to start to inject these patients?
So I tell the patient that they'll probably see a benefit beginning at a week. The full effect may be several weeks out, maybe 2 to 4 weeks out. And for most patients, it lasts about 3 months. I have some patients who last up to 6 months, and I have quite a few who wear off a few weeks before that 13-week visit. In Michigan, I'm limited to injecting every 91 days. I can't inject before 91 days. And for immunologic reasons, you probably don't want to anyways. So we really respect that boundary of 91 days. And some patients find that it's still working, and if it is, we'll push back the repeat injections, but a lot will tell me it's starting to wear off and the drooling is returning, but maybe not return to baseline by the time they come back.
And patients have had drooling for a long time, and yet in the studies, 1 week after injection, there's a significant improvement. So it can be a therapy that can be pretty reliable in its effect. How do you gauge response? Do you have patients come back in a week or a month, or do you have them call or keep notes, or how do you tend to figure out was it the right dose by knowing how much drooling there was?
A lot of my patients travel long distance, and it's not practical for them to come back. And so I ask them to keep notes, and I say, when you come back, I'm going to ask you the following things. So maybe write it down on your calendar. I'm going to ask you, when did it start working? I'm going to ask you, were there any side effects? When did the side effects start, and how long did they last? When it was working, what degree of benefit did you have? Did the drooling stop, or was it just reduced? Was it the coughing better at night, or is that reduced? So I'm going to ask them to gauge both the severity and duration of adverse effects as well as the degree of benefit. And then I'm going to want them to tell me when it wore off. So I tell them, these are the things I'm going to want you to do. And I'm speaking to the caregiver at this point. And I said, try to mark it down on your calendar so when you come back, we can have a discussion that helps me know how to modify the injection dosing or the sites for the next visit.